I'm with the Massachusetts Housing and Shelter Alliance. To give you a little background, the Massachusetts Housing and Shelter Alliance is an advocacy policy organization that's member-driven, has over 90 members statewide through the Commonwealth of Massachusetts. What's unique about the Massachusetts Housing and Shelter Alliance is the fact that it is not a trade association. That is, it does not exist for the institutional well-being of its various members, but rather the members are a group that are committed to the idea that homelessness is wrong and that there's a better response to the problem than emergency shelters. And Mahasa plays a role in terms of generating resources for our members, but also becoming an incubator of sorts, a place through this delivery of service network that's been created around the Commonwealth. We can create specific initiatives and then measure their outcomes. And I was thinking back, in the early 1990s, there was a mass shelter provider in Massachusetts, a rather large sheltering interest, so to speak, who had written a journal article within an academic journal dedicated to homelessness. And that specific article was making the case that emergency shelters should exist and institutionalized as an appropriate housing niche for a group of people that essentially that was the best you could do for. And from my perspective, and being part of this thing, again, I'm not a researcher, I'm not a sociologist, which will become painfully apparent as we go on. What I am essentially is I'm an advocate and I'm a provider. But it has always been repulsive to me is the notion that sheltering is the best we can do. And for the rest of the folks who can't even comply or make it within the shelter, they remain on the streets. That is the principle that the Massachusetts Housing and Shelter Alliance, both when I was a member and participating as a provider, that's why it was so important. Because it was the one voice together that was saying we could do better than this. And around 2003, I actually took over. And I took over at an opportune time because a lot was happening in Massachusetts around the issue of health care to begin with. And I had been batting my head against the wall in terms of figuring out ways of creating more low-threshold, permanent supportive housing, housing-first models that we in turn could test. Things were happening here in New York already, God's honest truth, almost for a decade at that point, in terms of people who were trying different approaches and doing something different. Again, we had two significant accomplishments that started to occur around 2005, 2006. But part of the story is I was sitting in my office and I always had a great name for what we were going to do. I was going to call it Home for Good. Little did I know that there was probably about 30 other people who'd already come across that name. But one day, a young physician from Boston Healthcare for the Homeless by the name of Jessie Gaeta walked in. And she had stumbled across a Soros Foundation program that funded so-called physician advocates. But as she came in, she said, you know, it gets frustrating to be serving somebody on the street or patching them up in a clinic, knowing that they would go right back out and not be able to maintain or sustain their health care in that situation. And again, just knowing they're going to keep coming back and recognizing that what would really work is housing. And she said, I've got this grant. I can become a physician advocate and work part-time for you if you be willing just to say, you teach me everything you know about advocacy. And I said, well, that's fine. I said, but you're going to have to reciprocate because in turn, you're going to have to teach me everything that you know about healthcare. And again, that was the most opportune, great moment because that was when the program called Home and Healthy for Good was born. Home and Healthy for Good was a state-funded program that was actually created through the legislature. And it began in September of '06. And again, we have presently up to about 1.4 million in that particular program. What was unique and what the providers liked about this was it was designed as a so-called flexible funding program. Home and Healthy for Good does not pay for anything in its entirety. Essentially, it's a leveraged fidelity-based model that we refer to, is that we try to bring it in as extra resources that providers in turn can then leverage other resources, whether those be federal, state, municipal, or even private resources, in a way that the trade-off is that they were going to take a risk in doing more of that low-threshold, non-compliance-based housing, which means, quite honestly, that if somebody is not clean and sober, they don't lose their housing on the account of that. If they don't keep their case management appointments, if they don't comply with some of the basic things other than being a good tenant, they still don't lose their housing. And that's what we mean by this low threshold model. Eventually, what happened, it probably took off faster than it was good for it in some regards, because it was immediately adopted after time by the state as kind of the model for approaching long-term chronic homelessness. Part of it was unique was that the cost analysis or cost evaluation was actually mandated by the state. And to date, there have been about 674 people who've been housed through this program. The retention rate, which again is kind of a misleading statistic given the numbers of unknown as well, but it's around 84%. The interesting thing about Massachusetts is that, and this is through a great deal, through not just through the work of Mahasa, but particularly through the work of Jim O'Connell, Boston Healthcare for the Homeless, is that there was significant periods of enrollment of homeless persons into Mass Health. And the program itself was designed to meet the very specific needs of homeless persons. And so even as we moved towards health reform back in the mid-2000s, one of the things that was recognized that there were significant numbers of persons who were chronically homeless in streets or in shelters who actually were already enrollees of Mass Health, the Commonwealth's state Medicaid program. Interestingly enough, at the same time, one of the things that Mahasa had been involved with is through the carve-out, the 1115 waiver of Massachusetts, we were able to come up with a program called CSPEC, working with the Massachusetts Behavioral Health Partnership, the private managed care organization overseeing the carve-out, where we were actually able to get additional resources through Medicaid that supported tenant-based community support services in various housing programs. And they did not even have to be licensed entities. They could work out with licensed entities, subcontracts that were tying together housing initiatives with specific behavioral health agencies and organizations. But you can see the driving force. We wanted to tie the homeless issue into the issue of healthcare reform that was happening at the time. And out of the people, you can see that the significant numbers of people, and these were not selected, these are just who they are, were receiving their benefits at that point in time through Mass Health. What became apparent, and Arturo's already shared his numbers, and believe me, the methodology that they've utilized is probably much more reliable than our own, although this was not advocacy science. This was, again, participating with Dr. Gaeta and the Boston Healthcare for the Homeless, through Boston University as well, to monitor these things. But again, what became apparent were significant savings. The data that you see there is kind of a combination of extrapolated Medicaid data, but also when we first started this program, again, we collect on a regular basis self-presenting data that the tenants themselves were providing. And again, roughly, it came out a post-housing savings of $9,300 on average per person. But what really started to attract the attention was not the analysis that we did, but the analysis that Mass Health eventually started to do. When they looked at the first cohort of people, they were amazed to discover that there was about a 67% reduction in the cost of Medicaid from, again, pre-housing to post-housing. that caught everybody's interest at that particular point in time, and that they are finding that the numbers are fairly consistent and continue to show, on average, healthcare savings that result from, again, housing, the permanent supportive housing. What happened next, and is of more recent vintage, is that through a grant with the Oak Foundation and Citizens Bank, and working in partnership with some of the work that Boston Healthcare for the Homeless was already doing, and what the Boston Public Health Commission was doing, we decided to do a far more targeted approach that was called Hughes to Home. And what this does is it serves patients that they identified, to begin with, the top 30 high-cost users of emergency and acute services, coming out of, at that point in time, Boston Medical Center. I understand now that it's expanding somewhat to look at a couple of other hospitals within Boston as well. But as you can see, that they outlined their program goals were to improve health and housing outcomes for this population, to again place them in housing, but to reduce utilization of expensive acute medical services. Because just as Arturo pointed out, the greatest savings were to be found in the acute hospital stays. The results to date are pretty amazing. And again, as we always tell people who are serving this population, we're not saying it's easier, we are saying it's more cost effective. I cannot tell you the challenges that the Boston Public Health Commission, Boston Healthcare for the Homeless face in keeping this particular population housed, but they are significant. I think, including one story, one person has actually been rehoused 3 times. Again, we're talking about long, extensive histories of addiction, mental health issues, and usually both. But as you can see, the results are still very promising. 56% reduction in emergency room visits, 33% reduction in inpatient hospital stays, and 86% reduction in emergency transports. A great deal of this work has been compiled through Dr. Gate, and I'm happy that Mahas is actually going to be helping finance some more targeted research in relation to some of these results in the very near future. So again, the result to date, 29 high utilizers were housed. Again, they followed this utilization that, as you can see, that they tracked their utilization through these various hospitals, and what they indicate, a 56% reduction in those visits, the stuff that I've already mentioned. It should be noted that of these, 3 have returned to homelessness, and 3 also in this particular program died. And again, those are people who were so compromised, in all likelihood, at least we can say that they died in housing. There's a footnote below that Dr. Gator, and this is all Dr. Gator's work from Boston Healthcare for the Homeless, but she did note that there was one outlier who had such an extreme number of hospitalizations that they left them out for that, but even with him, there's still a 49% reduction in emergency room visits and a 15% reduction in inpatient services. So with that, I think keep the story in mind. As it was mentioned at before the keynote, that we're at this key moment in time where healthcare is still a critical issue in a time of transformation. I think the advocacy component becomes very clear to us that if we're talking about integrated care, if we're talking about ways of delivering healthcare services better, more effectively, then certainly housing needs to be considered one of the most critical parts of that integrated care. Thank you.